Alright, in this section we're going to be talking about drugs that help with the gastrointestinal system and also adrenal steroids. So we'll start with the GI tract and digestion. You start making gastric acid, gastric juices, even before you eat. So when you see food, when you smell food, when you think about food, you start secreting gastric juices. That's going to include hydrochloric acid and the production of pepsin, which is an enzyme that digests protein. And then when you eat, when the food gets down into the stomach, it causes it to stretch. And that stretch can cause release of gastrin and histamine, which then also sets off more gastric acid production, so you can have more pepsin production. And then, as the food moves from the stomach down into the duodenum, you start turning things off. So, secretin and cholecytokinin, CCK, turn off your gastric acid production, because you don't want to have a bunch of acid sitting in your stomach when you don't have any food in there, right? And you also don't want a bunch of acid down here in the duodenum. That is bad. So this is regulated with acetylcholine. Acetylcholine binds pretty much everything. So when the vagus nerve, you can look at the vagus nerve up here, when it comes and releases acetylcholine, it kind of just starts turning on all these different cells. So it turns on the parietal cells, the chief cells, and starts increasing acid production, gastrin production, which then also increases acid production. Gastrin binds your parietal cells in these ECL cells, and this is going to cause the parietal cells will release hydrochloric acid. The ECL cells will release histamine. Histamine binds its H2 receptors on these parietal cells, which will cause more hydrochloric acid to be released. And so you just start getting this buildup of all this acid in the stomach to about a pH of about 0.08 or around 1, which is really acidic, right? So acidic that it can cause peptic ulcers. So peptic ulcers are going to be these open sores that you will find on the lining of the stomach and sometimes in the duodenum. Typically it should look like this, but with an ulcer you have that lining gone of the mucosa. Of course you're going to find it where there's acid and pepsin. So you kind of have this barrier between your mucosal cells and the stomach acid, and it's this sodium bicarbonate barrier, a mucosal barrier that stops the acid from eating away at the stomach, because, I mean, the lining of the stomach is protein, right? There's a lot of protein in those cells, and so it can damage it. Symptoms, you're going to have periodic pain. Depends where it is. So if it's in the duodenum, you'll have pain when you're not eating. And if it's in the stomach, you'll have pain when you are eating. You'll also have nausea, loss of appetite because it hurts, and vomiting. The pain is typically described as being really dull or a gnawing or a burning. It kind of feels like heartburn, except, you know, it's going to be coming and going based on when you're eating. But it can lead to perforation, so it can eat all the way through that lining. And then you'll start having blood either in the stools or in your vomit, which is not good. Another thing you can have is called GERD. GERD stands for Gastrointestinal Esophageal Reflux Disease. So it is like a chronic heartburn. This chronic heartburn can lead to ulcerative esophagitis. So basically you're going to get ulcers in your esophagus, again, because it is made of protein, and all that acid that keeps going up in there damages the esophagus over time. It can cause strictures and fibrosis bands in the esophagus, which then makes it hard to swallow stuff, like pills or even like food. Food can start getting stuck in your esophagus if you have chronic heartburn or GERD. And then you'll have to go in and have like esophageal surgery where they like stretch it out and stuff. What really causes the GERD is an over-relaxed lower esophageal sphincter. Things that can cause that sphincter to relax would be food like chocolate or foods that are high in fat, like pizza, like pepperoni, steak. Onions can cause it, coffee can cause it, peppermint can cause it, and so can spearmint. And then, of course, drugs like alcohol or calcium channel blockers can cause it. Cigarettes and morphine, dopamine, diazepam, your barbiturates, and then some prostaglandins and digestive hormones. Some prostaglandins can also cause it to tighten up. It just depends on which ones you have. So the drugs we use to treat ulcers are pretty varied. You can have your antacids, so they're going to increase the pH, right? They are antacid. They are basic things like sodium bicarbonate that you take, and it just kind of counteracts the acid in there to make it less acidic. You can also take GI stimulants. These are going to be drugs that mimic acetylcholine, like banthacol, uracil. And so what it does is it causes the contraction and the movement lower down and can increase the strength or the contraction within that lower esophageal sphincter to stop the GERD or the reflux going on. H2 antagonist, histamine, increases stomach acid. And so you can take stuff that decreases your histamine. You can take antihistamines for peptic ulcers or reflux. Like Pepcid and Zantac are two examples of H2 agonists. These were really the first drugs to hit the market to take care of the acid production. So you can have things that decrease the acidity, but these actually decrease the overall production of the acid. And even better than that are these proton pump inhibitors, the PPIs. They inhibit the acid secretion and the volume. This just decreases the acid and the volume. So they're pretty similar, but your proton pumps work better. Examples would be like Nexium, Prevacid, Prilosec, Omeprazole. And then, of course, lifestyle modification, especially with GERD. Like, if you drink a lot of alcohol, stop drinking a lot of alcohol. And then your lower esophageal sphincter will tighten up. It also reduces the volume in the stomach. GERD typically is worse when people are laying down because it helps to push that food or that acid up to that lower esophageal sphincter. And so there's a lot of different things you can do to get rid of GERD without having to take different types of pharmaceuticals. You can also get ulcers from H. pylori. It's a bacteria. It can invade your ulcers and make them worse and make it where they are not healing. To do this, we typically do a double antibiotic. Sometimes do something called triple therapy where you add in bismuth, or even quadruple therapy where you add in a PPI. The antibiotics to treat H. pylori are stuff like amoxicillin, tetracycline, clarithromycin. These are pretty common ones. They work really good against pylori. You really want to use two different antibiotics because pylori is pretty resistant, and you really want to knock it out so it doesn't build up more antibiotic resistance. And of course, we'll be talking about antibiotics later on in the semester. Bismuth is found in Pepto-Bismol, kaopectate, some of the over-the-counter heartburn meds, or GI meds. And it's believed that it lyses the cell wall of H. pylori and may also decrease the adhesion to the ulcer, so it's going to break it up. and make it easier for these antibiotics to attack it. And then your PPI just helps speed up the healing process of the ulcer. So it doesn't actually work on H. pylori itself, but it heals that ulcer quicker because the acid is less. Alright, so the first drugs we're going to talk about are the H2 antagonists, just because they are historically important. So, with your H2 antagonist, it typically heals your ulcer within about a month. You're not supposed to take these for longer than about 6 weeks, because it's not going to, like, speed up or heal any more ulcers if you have those, if they keep building up. Side effects, pretty mild, with headache, maybe constipation. So, here with your H2 agonist, your ECL cells, they secrete histamine. You can block that histamine from binding its H2 receptor. If you remember, H1 receptors were the receptors that were like responsible for allergies and your allergic responses. These H2s are responsible for the secretion of stomach acid, right? And so it can block histamine from binding to these parietal cells or these gastric glands. And here you can see how they make the stomach acid. Not something you're going to be tested on. Something to take into consideration with your H2 antagonist is that they interact with your CYP450 enzymes. These are specific liver enzymes that metabolize a bunch of drugs. And so a lot of your H2s are going to be contraindicated with a lot of different drugs like benzodiazepines, barbiturates. And so if you take your H2 antagonist, it could either increase the action of the drug or decrease it depending on how it is working with those enzymes. Sometimes it can cause them to increase the number of enzymes, and so your drugs aren't going to work as well. Or it's going to bind up those enzymes, and so you're going to have your drug hanging out longer. It's going to have a larger effect. Then we have our PPIs. These were just approved back in 1990, so they're really not that old. They haven't been on the market, 30 years now, but they're better at acid suppression and ulcer healing than those H2 antagonists, and are now kind of the go-to drug. They also use your CYP450, and so they can elevate levels of like diazepam, phenytoin, warfarin, and they decrease the effects of Plavix, so clopidogrel, the anti-clotting drug. If you take it, it can decrease the effects of that. How these work is they inhibit this proton pump. And so with your hydrogen, potassium, ATPase, you're not going to be secreting more acid. This next drug is an anti-ulcer drug. It's called sucralfate or carafate. And what it is it's aluminum hydroxide with the sulfated sucrose. And it helps to heal the ulcers without changing any of the dynamics within the stomach. So it's not going to change the amount of acid produced, the pH of that acid. It's not going to change any of your pepsin or anything like that. What it does is it binds albumin and fibrinogen. So when you look at your ulcers, you can see that that mucosal lining's not there. And so albumin is a common blood protein. You'll have blood vessels here that may be ruptured, that may be actively bleeding. And so sucralfate can bind to that. And also fibrinogen, pretty common blood protein, makes fibrin. And so it binds to that, and what it does is it kind of creates like a protective barrier so the acid can't attack that ulcer more, right? And so with that barrier, it helps to speed up the healing process. Really indicated for your duodenal ulcers, not so much for your stomach ulcers. It does affect the absorption of DIG, quinolone, quinidine, ketoconazole, and warfarin, so a lot of your heart meds. So just be aware of that. It will decrease the absorption, so you're going to have a lower amount making it into your systemic circulation. The next one is metoclopramide. This is a prokinetic drug, kind of like bentacol, where it is going to enhance the tissue's response to acetylcholine. So it's not an acetylcholine mimic like bentacol, but it just enhances acetylcholine. It's used to treat GERD because it causes a tightening of that lower esophageal sphincter because it is enhancing the acetylcholine. And so it's going to increase the movement of your intestines, of your stomach, of your food. That's why it's called a prokinetic. It also antagonizes D2 receptors in the central nervous system, so it's pretty good as an antiemetic. So it decreases vomiting, and it can be used to chemotherapy to decrease vomiting associated with that. It can cause tachycardia, fatigue, restlessness, diarrhea, and then prolonged use can cause tardive dyskinesia. Tardive dyskinesia is kind of like repetitive muscle twitches, kind of like what you see in people with Tourette's, where they might like smack their lips or clench their hands repeatedly. Speaking of vomiting, this is another GI issue that we will be talking about. So vomiting is a complex, highly controlled reflex. It happens if you get hurt really bad. It happens if you eat something that is poisonous. It happens if you drink too much alcohol. It happens if you get too dizzy. There's a lot of different things that can set it off. And there's going to be a lot of receptors that are associated with it. So acetylcholine with this vestibular system, and so acetylcholine antagonists like scopolamine can work. You also have dopamine receptors. You have this special receptor called an NK1, which we'll talk about, serotonin receptors, and then muscarinics again. And you're going to have two control centers. So you have one that is the vomiting center, your VC, right, down here in the medulla. And then you also have your chemoreceptor trigger zone, which is also down here in the medulla. And so they're receiving signals from the inner ear. They're also getting signals from the vagus nerve that comes in here, also from the central nervous system. So a lot of different signals are working on these two centers to cause vomiting. Pretty much with your chemoreceptor trigger zone, this one's only going to be responding to noxious chemicals, while your vomiting center, stuff like if your stomach is stretched too far, if you're in pain, if your inner ear is telling you that you're dizzy, that can all go here to the vomiting center to cause vomiting. So antiemetics, drugs that stop you from vomiting. They're used from anything from like morning sickness all the way to chemotherapy. With chemotherapy, typically use your serotonin antagonist prophylactically. Serotonin antagonists are stuff like Zofran, Dolostone, Paleonostone. And what they do is they block the serotonin trigger at both the GI mucosa and at your vomiting centers, at the vomiting center and the chemo center. With that decrease of serotonin, you can get dizziness, sleepiness, muscle cramps, pretty common side effects. Neurokinin 1, so this is at NK1, so you have a receptor in the vomiting, in the CTZ, that bind substance P, which is related with pain, right? And so substance P binds this receptor, this neurokinin 1 receptor, to cause vomiting with those. But amend can block that receptor, can block substance P from binding it, and so you're not going to get vomiting from those. And then another is a phosphorated carbohydrate solution. It's just fructose, dextrose, and phosphoric acid. What this does is it works in the stomach by making it hyperosmolar. So it really increases the molarity within the stomach, which is going to delay the stomach emptying. It's also going to relax the smooth muscle there. So you're not going to get the stomach really squeezing to force the vomit out. And cool thing about it is it's super safe. It's just fructose, dextrose, and phosphoric acid. And so it's really useful for morning sickness, for anybody who's pregnant. Also for children, it's safe, versus some of these other ones might not be okay for them to take. We're going to stop there and pick up with adrenal steroids next.